Okay, welcome back. Thank you for joining us for our Lunch and Learn, and I am so thrilled to be able to have such a great team with me here today to relay the experience that the VA has, the Veteran Health Administration, and the experience of telehealth, especially with the response of the COVID-19 pandemic. And I think all of us are looking to those leaders that are able to make, all of the changes at once, policy and delivery changes. And we look to our partners here at the VA to be able to kind of show us the way. And also as key partners to be able to demonstrate that evidence base when we are speaking with other policymakers and legislative staff on the experience and what we can learn from their work. So let me introduce who we have here today. I'll start with Dr. Susan Kirsch, who is our Acting Assistant Deputy Director for the Secretary of Health and also leads Access for Care for the VHA. And she is joined by her colleague, Dr. Lisa Arfons, who is also the Acting Clinical Deputy of Office of Veterans Access to Care. And we are also joined with Dr. Ken Kaiser, who is working now as Vice President of Atlas Research, but has also been a true partner of all of ours in California in leading the way of adopting innovation and telehealth. So I introduce all three of you. I know that I'm going to hand it over to Dr. Kaiser to get us started. And since this is our Lunch and Learn, we're hoping that this gives you all an opportunity to grab a bite to eat, grab that extra cup of coffee. And Dr. Kaiser, Dr. Kirsch, Dr. Arfons, I hope that I can also jump in with some questions as they come in to hopefully give us a bit of interaction. So Dr. Kaiser, I'm going to hand it over to you.
Great. Thank you, Timmy. It is great to be with you today again. And once more, let me extend my compliments for putting on such a great program. This has really been fascinating. Let me just jump right into it. I see that Dr. Arfons and Dr. Kirsch hopefully is with us. There you are, Susan. Had some technical issues had to be overcome earlier, but I think it goes without saying that the COVID-19 pandemic has really dramatically altered our patterns of care delivery here in the U.S. and indeed throughout the world. One of the responses has been the dramatic increase in the use of telehealth and other forms of virtual care, which has been done both to keep care delivery going and at the same time as trying to keep both patients and providers as safe as possible. As I think is reasonably well known, VA has been a pioneer in telehealth, has been using telehealth for well over 20 years. But its efforts were certainly catalyzed and markedly increased in response to the COVID pandemic. So I'm pleased that we have a few minutes here today to talk about some of the things that VA has done, not only to respond to the COVID pandemic per se, but what it's doing to try to sustain the changes that have occurred in response, and how it's trying to address some of the questions, the outstanding questions about the role of telehealth and virtual care in the future. And just piggybacking on to one of the questions at the end of the last session about where are the data gaps, I would only say there are really huge data gaps, and there's a lot that has to be determined and worked through. And I think VA is going to provide a number of those answers going forward. So with that, let me turn it over to Drs. Kirsch and Arfons, who will show some slides, and then hopefully we'll have time for some conversation later. Susan?
Thanks for that introduction, Ken. And I think that you covered this slide in part, really what did we learn in the beginning of this pandemic, and where are we at now, and how do we sustain some of that change? Dr. Lisa Arfons is in the Access office in which I lead, and she's on as a provider of video to home virtual care delivery. So she's going to make some comments and leading some of the special care effort. So the next slide, please. I recall how months ago, right, Ken, I saw this figure probably around the May time frame, and I showed this to Ken, and I said, I think this is important, and we should write something up. And on July 1st, you can see the reference is actually in the blue at the bottom. We published a manuscript in New England Journal Catalyst that shared what had happened in VA, and wanted to share some of what we learned to see if that could be useful or helpful in other systems. So I'm going to run through some of these slides relatively quickly, a few of them, so that we can get to some of the questions that we're really facing right now, and how to continue to be thoughtful and move implementation forward. So really escalation in that last slide of the video to home or video connect appointments, predominantly in mental health and primary care, but still escalation or augmentation in specialty care. Video to home is really what we, or VVC is a product that we put together years before there's been a lot of commercial work. So in case you hear me lapsing to video to home or VVC, it's interchangeable. But it is really a video appointment with a provider. So,
Susan?
Yes.
Can we go back a slide?
Uh-huh.
Can you just describe, so we have mental health, primary care, specialty, and other. Can you describe what the other is?
Good point. So the other is social workers, chaplain, and some of the ancillary services. We're looking at this opportunity to provide clinical care or visits in that way as well. Some of the MOVE clinics for weight loss programming, smoking. So it's outside of the more physician-based programs.
Wonderful. Thank you. Thanks.
Yeah, I would just call out as well that when you're looking at this and viewing the numbers there, these are 30, 40, 50,000 per week. So the numbers are pretty large.
And as mentioned, the specialty care, went from a few thousand up to over 10,000 in a week. And right now, we're looking at about 36,000 visits a day across medical and surgical specialties.
And Dr. Kirsch, Susan, you may not have this at the top of your head, but also, can you just scope out what the VA footprint is in California for those that may not be aware?
Yep, that's a good question.
8 medical centers.
Networks.
There's Dr. Kaiser.
What'd you say?
No, eight medical centers.
I bet there's more than that, but okay. I'd have to count, probably 10. Yeah, right. There's Vision 21 and Vision 22. I know that's a good question that we could get back to.
We can follow up, during the day. Yep. Great.
Absolutely. So big. It's big, right? California is big, and the VA takes care of 9 million patients across the country, so it's big. Yeah.
Thank you.
So that's why, in part, Timmy, we thought that sharing some of what we learned in such a huge organization, and the fact that we were able to flip pretty quickly to virtual, what perhaps could be some lessons learned. Okay, so I'm going to run through the next few slides to get to some, I think, more thought-provoking questions further. Interestingly, this was also in the manuscript, and primary care went to initially a bit more of the phone visits. In discussion with primary care leaders nationally, really felt that a lot of those patients had relationships, so it was easy to get to a phone visit and do that and scale that quickly. But there's some different data that I have later on in the slide deck to talk about what happened in the journey of primary care and their virtual care. So next slide, even e-consults went up significantly, and we spoke a bit about that yesterday, spoke about gastroenterology and some of the review of some of the work that was submitted, the referrals that were submitted, and how in some ways this, another thought-provoking comment here for the question and answer session is really, is there some unnecessary care that could be answered and taken care of through e-consults? Just food for thought there. So next slide. This really, overall, our telephone and video care really accelerated us forward. We have a huge organization. We did escalate. From the first telehealth chief telehealth officer in late 90s under Dr. Kaiser to 2020, we're really pushing the envelope like many others and expedited our really augmentation of this work, like many of you. Next slide, please. So what do we learn? I think about this. I started thinking about this a lot a few months ago, engagement, and what does it take to really move the needle forward and keep it moving forward. And I thought about it really as 4 prongs or 4 legs to a stool, whatever analogy you may want to use, that you needed to really engage the veteran and help the veteran or the patient become knowledgeable about what could be accomplished through virtual care, make sure that they feel comfortable using that technology and how it could help include a family member in the visit that may be remote. So they're helping the veteran understand the benefits of using video to home visits, and then the clinician. Some clinicians are more amenable to using technology in this fashion. We have seen in our system, primary care and mental health have been more aligned with embracing, a little bit slower in medical and surgical specialty. And then the third of the 4 key areas are the schedulers, because patients call in and ask schedulers, well, what would you do? Or you're scheduling this for me, what should I know? I think that for our system in particular, it was an important point to be able to educate schedulers about this work and how important it is in keeping patients safe and still delivering them the care they need. And the last is really how do all of those interface with technology, because that's really the enabler or the facilitator here. Looking at the digital divide, we provided thousands of tablets, and we cited that in that manuscript and distributed across the country. We also expanded our broadband. Our IT partners helped to literally expand the broadband early on in the pandemic. And then also really we have the opportunity to have someone who's licensed in Florida and be able to, as a physician, provide virtual care delivery in California because of our legislature. And we realized that we needed to, like everyone else, make sure that the workload was there and the reimbursement was there. But of interest to me and to Dr. Arfons has been working with a gentleman in, I think, Greater Los Angeles VA in California, and he really has helped us think about what is that interaction between the veteran and the provider. How is that different in a virtual environment? And we've heard Tom Lee and some Prescaney talk about that as well. It's not exactly the same. If you look away, right, it looks like you're not paying attention, but maybe you're taking notes and cueing patients to things like that. So some of that work, some Greater Los Angeles providers helped us do some training. Okay, next slide, I think, is our Anywhere to Anywhere legislature that allowed us in the last couple of years to have a provider in one side of the country delivering care in another side of the country. And next slide. So really focusing a little bit more on how we can sustain some of these changes moving forward. What does it mean to access going forward, particularly in the current environment with increased COVID cases? We need to maintain this. Next slide, please. And I have 2 slides that really point to the total number of appointments that we deliver. We compare to last fiscal year, as we're on fiscal years, October to end of September is a fiscal year, and for anyone who does not know that. And we maintained about the same amount of total number of visits between face-to-face, telephone, and video to home appointments, and that's really the total number across the top. And of appointments over time since January. And again, it's been about the same amount of appointments, but you can see the flip where we're doing less in face-to-face in primary care, and then between telephone and telehealth, we're making up the difference. There has been an expectation to maintain this amount of virtual care in our pre-policy pre-policy fashion, expecting that from primary care to sustain this in this way, even augment it when need be or possible.
And Susan, just to be clear on the gray line, which is telephonic, is that include video or is it pure telephonic?
It's for telephones.
Wow.
And the CVT is clinical video telehealth and video connect. That's really our data cubes and what it says on the data cube. So the gray, thank you for pointing that out, is telephone care, and the orange is the video to home care with a little bit of clinical video telehealth and dermatology and some of our sleep studies and such. So we're including all of that virtual type telehealth care into that orange line.
So,
thank you.
Dr. Kirsch, just a quick comment. The curve that are shown here really closely parallel what is seen, what has been seen with Medicare Advantage plans, their private systems, as far as a really big bump in the use of virtual care in the March, April timeframe, and then a kind of a slow decrement with a pickup of face-to-face visits. The one notable difference, though, is that, for example, with Medicare Advantage, there has been an overall decrement of care of around 20 or 25% of visits, whereas what you see here is actually the total number of visits has remained relatively constant throughout. So that, it's something interesting there that may want to be looked at going forward.
I appreciate that. I think that in our patient population in primary care and mental health, there was a significant amount of outreach, knowing that we wanted to be proactive really and look at more at-risk populations and reach out. Okay, so next slide, please. Thank you for that, Dr. Kaiser. And then in mental health, again, we maintained about the same amount of appointments and had really a decrement in our face-to-face visits. Interestingly, and I always think about this, is really how important that video care is in a mental health patient. As you think about, you can see the context of their home and you want to see their affect. So coming in and maintaining or wearing a mask is not as useful or helpful. So really those things are striking to me. We continue to have high numbers of video to home and telephone for mental health care. So I'm going to now turn it over to Dr. Arfons as a specialty provider, still seeing patients in Cleveland virtually sometimes, to help lead us into where we're going with specialty care, and that includes both medical and surgical specialty. We know that it's been a little bit more challenging for these providers, and so we had to come up with more specific plans on how to engage with them and staff and move this effort forward. Lisa?
Great, thank you, Susan and Ken and Timmy. So as Dr. Kirsch mentioned, we're doing a bit of a deeper dive with specialty care. We do understand that they are more heterogeneous, both in their adoption and ability, due to the medical indications and just their specific specialty about how they can deliver virtual care. That being said, we do truly feel that there is a floor and a minimum that sort of transcends all specialties. And then what we want to do then is build on then each individual specialty to sort of maximize the right mix of not just virtual synchronous care, but you can see here e-consults, other telephone care, et cetera. So Susan talked about the scheduler readiness, the provider communication trainings. We have set as the floor a 10% increase from a pre-COVID specialty or an increase that we want to see by the end of December, and that is over each facility. So it is giving facility leadership flexibility and understanding where they want to focus on VDC expansion with their specialty care leaders as well. We're
And
also
Lisa, is this
providing
across all of the visits?
well, so this, yes, across every medical center is being held to the 10% increase. Again, the facilities themselves then can decide how to sort of delineate and what will make up that 10%. We are then providing data, such as what you see here on the right, that is, not showing any absolute target, but just giving you a sense of in sleep medicine. This is one facility, we've not shown it. Right now is delivering in the green, I believe that's about 13% is e-consults, 20%, 30% is face-to-face, other telehealth, 25%, and so on. So then facility leadership can use this to have more detailed discussions with their providers to say, listen, pharmacy, you're doing a great job with e-consults. Can this be applied elsewhere? Plastic surgery, you're doing a lot of face-to-face care. How can we expand and have you learn from the other specialties, surgical services that are delivering more virtual care? We can go to the next slide. And I think these next two slides, we don't have to spend a lot of time on given time constraints, just to show that we have a lot of individuals in services that were very interested in joining our specialty care expansion. We reached out to all of them. And then this slide, we have especially a lot of surgery engagement, but this just gives you a sense right now that we set this 10% floor, as I mentioned, and you can see here for spinal surgery, for instance, they're nearly 400% increased. Now, yes, some of the numbers are small, but we really have a lot of great physician engagement in a lot of these specialties. Next slide, please. Obviously, if there was any silver lining, I even say this to my veterans of COVID, it has been just the rapid expansion of virtual care. And I, as a VA employee, not someone who works for central office, but delivers care, have been so impressed at the VA's ability to pivot so rapidly with OINP, everyone truly to expand virtual care delivery during this time. And we really have continued to run with that. We still want it to remain the primary modality of care when it's safest to do so and clinically appropriate. But we do understand, as I mentioned, that there is variability in adoption. So we're working on setting the floor and expanding from there. Next slide, please. And then just speaking of other virtual care opportunities, we're working with some of our external stakeholders as well to innovate and expand the ability to offer this in certain specialties. Next.
Let me just make a brief comment on that last slide is that, I have to understand that telehealth doesn't exist in a vacuum. And that the use of telehealth is actually catalyzing innovation in a number of other areas. And there's some mutually reinforcing dynamics here between some of the technologies that are evolving in other areas to support the use of telehealth. So we have to, I think, keep in mind that telehealth is part of a larger ecosystem here, and that in and of itself, it is catalyzing developments in other technologies as well.
Yeah, and it's just definitely a highlight for us because as part of the coalition, we're looking at remote patient monitoring as a priority next year. And, looking at your experience base here and your next publication, we hope, will really help us along that way.
We're looking at piloting in a lot of these areas, partnering with outside business entities and testing some of these that are listed here to see what really works before we would further scale things. And then I think second to last slide is next, and it's mine. And that is really during this time period of virtual care, the telephone systems and delivering of virtual care through our clinical contact centers has become an enterprise-wide effort and priority. And that includes the use of not just answering the phones, but answering the phones with escalation to licensed independent practitioners, with pharmacy refills, as well as clinical pharmacy specialists, and getting appointments scheduled. Those are expectations of every single network now across the country. Is a project that now has moved into the Access office, and really engaging with the customer relations management software, which really escalates the capabilities. When a patient calls in, the software allows you to see, you're calling for your earache, but I see on the screen that you're out of your diabetes and your hypertension meds. Can I go ahead and refill them for you? And I think that takes really this type of an effort using the modernization efforts of the CRM, the omni-channel. Technology enables us to really take care of the acute and then address perhaps some chronic and maintenance care for patients as well, prevention. And so I think I'll turn it over to you, Dr. Kaiser, for the last of our official slides.
And actually, I'm mindful of the clock, and I see quite a large number of
Okay.
questions. So let me just make a couple of points, and then hopefully we'll have time to get to some of the questions. But I think some of the key issues that are being focused on going forward is, as has already been noted, is what's the right mix of telehealth / virtual care with in-person care, and that really has to be sorted out. I know this is the question that lots of payers have, and so there's a lot of data gaps there that need to be filled in. I think there was a very poignant question at the end of the last session about workforce, and some data that just recently, I think it was at the end of last week, came out, is that since the beginning of the COVID pandemic, 8% of physician practices have closed. Nationally, that's about 16,000 practices. I'm mindful in California that in many counties, 50% or so of the physicians are thinking about, or were thinking about prior to COVID, of retiring, and the pandemic is accelerating that. So there are some real serious workforce issues which telehealth could be a big part of the solution addressing going forward, but lots more to be worked out there going forward. I think another point that was touched on earlier was just the delayed care, deferred care due to COVID. And one of the things that Dr. Kirsch and her colleagues are looking at now is how can telehealth be used to catch up on some of that, particularly some of the high impact preventive care that people have put off, for fear of going into a healthcare facility during the pandemic. And maybe just a last point I would throw out here among several others it could be, is that really, going to many of the questions that have been raised today as well as yesterday about how do we maintain the advances, I would consider them advances or progress in the use of telehealth, that we really have to think about this as a cultural change phenomena. It's larger than telehealth. We really have to think about what are the levers we can pull to change the culture so that getting a virtual visit really becomes the default mode. That becomes the new normal. And then we are more selective about what actually has to be provided in person. So we really have to think about how do we change the culture 180 degrees from what it has been in the past. And there's lots of experience in California, for example. Smoking provides, I think, a lot of lessons here, and what the anti-tobacco use campaign has done. And there are a number of other examples that could be pointed to. So we need to look at what we can borrow from other efforts in changing the culture when we think about how we change the milieu for telehealth going forward. So with that, let me stop, Timmy, and I think we'd all be happy to try to address any questions that you might have at this point.
Well, thank you, and thank you for the summary, and I think hitting on really some of the key points for us to think about going forward. I think just with the very few minutes left we have, I'm going over just a bit. A quick question about your utilization data. It's incredible, and thank you, and we give you kudos for being able to track that and publish it in such a timely manner. Are you also looking at outcome data or quality data that can be a companion to that we can also learn from?
We are looking at that, but so that is being looked at. One other thing, though, that I thought was really important is getting veterans' feedback about the experience of flipping to virtual care. From particularly, there's been some literature about older patients and their experience. So we're looking at experience for patients as a component to continue this. More than just looking at systems-based outcomes, but the veteran, experience in this. And it's been pretty positive so far that they think that they wouldn't, they thought they would, they were surprised even themselves by what they got out of virtual visits. And we use something called V-Signals that captures more real-time veteran feedback. And we're exploring some other survey methodologies in comparison to private sector. But I think that's important to understand in addition to some of the system-wide measures for sure, like quality.
Well, we will definitely follow up with you on that if you don't mind.
Sure.
And I'm just going to ask one more question, which Dr. Alphonse, I know I was just, for those of us that had the benefit of hearing all three of you yesterday, just to picking up on the leadership that you've had in helping with your peer group and that culture change, and working with one of the specialists that you gave as an example of looking at their panel and helping them to think through what could be more appropriately served through telehealth. Can you just give that kind of a reflect on how we might be able to do that at scale going forward?
Can I say one quick thing, Lisa?
Yes.
Sure.
That is that Lisa's been working for us in the Access office, and in the beginning of this pandemic, when we were asking everyone the specialists in particular, to start doing video visits, she said, I can't be on a meeting this afternoon. I'm taking the training. I have to know how to do this and experience this for myself if I'm going to talk about it. Okay, go ahead, Lisa.
No, I definitely did. I had to walk the walk. That was important. And I think along those lines, it helps to have physician engagement and physician champions to even just, well, people will sit with me in the clinic room during an appointment, even if it's something that simple, just to really show people that it can be done. And then also trying to really look at the barriers and focus on what I think the barriers are of my own practice and how I could do better, and then see if that remains, and then how to scale to improve from there. But I think that physician champions, especially within your specialty, is very important.
Well, and we have those champions, yeah. Mm-hmm. We have these subgroups of cardiology, GI, pulmonary, oncology, and a general surgery, and some, I think, podiatry have been our biggest champions. Mm-hmm.
Yeah.
Well, fabulous. Well, thank you again, and we welcome you to be a partner as the coalition continues its efforts to adopt California policy to be able to accelerate telehealth going forward. Thank you again
for having us.